Welcome to Diagnosing Health Care, a podcast featuring thought-provoking conversations about the latest legal, policy, and regulatory issues in healthcare. While these issues may seem like hurdles, we'll also look at the business opportunities and solutions that exist. Diagnosing Healthcare is brought to you by the healthcare lawyers at Epstein Becker Green, a leading law firm that has more than 40 years' experience serving clients in the healthcare industry nationwide.
Today on Diagnosing Healthcare, we discuss the challenges that healthcare providers face in complying with the new interoperability rules, as well as the opportunities that achieving interoperability will open up. Hello, and welcome to our special series on interoperability. I'm your host, Nivedita Patel. I'm an attorney in Epstein Becker Green's healthcare and life sciences practice based out of our Washington, D.C. office. One of the goals of the 21st Century Cures Act and ONC's final rule related to interoperability and information blocking is to improve care coordination. By eliminating barriers to healthcare providers' access to data, a patient's healthcare provider will have much more comprehensive view of a patient's entire continuum of care. This should ultimately lead to better health outcomes. While the long-term goals are clear, healthcare providers are currently focused on compliance with the rules and the associated challenges. On today's show, we're going to hear from a healthcare provider's perspective and how providers are viewing their role in the healthcare ecosystem that is striving to achieve much needed interoperability. If you like what you hear today, please subscribe to the show. Diagnosing Healthcare is available wherever you get your podcasts. I want to hand things over to my colleague, Jenny Nelson Carney, a member of the firm in Epstein Becker Green's Columbus office. Jenny helps hospitals, health systems, and other providers navigate the complex issues surrounding maintenance of patient information, including interoperability and information blocking. Welcome, Jenny, and thank you so much for leading today's discussion.
Thank you so much, Nivedita. I'm so glad to be here. I'm glad to also be here today with my colleague and friend, Andrea Darby, who I've worked with for about 10 years. Andrea is the Vice President of IT Integration and Applications at OhioHealth. She's led the business operations and technical transition to interoperability compliance as OhioHealth has evolved from a hospital system to a health system. I'm thrilled that she is willing to share her vast knowledge with our audience today. Welcome, Andrea. Thank you so much for being here.
Thank you, Jenny. Looking forward to the discussion today.
Wonderful. The UNC's Cures Act final rule is designed to give patients and their healthcare providers secure access to health information. The rule also implemented the information blocking provisions of the Cures Act and outlines 8 exceptions to the definition of information blocking. Very exciting stuff. The things that we've been talking about for a while, as everybody in the healthcare provider world in particular has tried to unpack what this all means. Andrea, there's been a lot of discussion around the perceived paradigm shift surrounding information blocking, meaning a movement from the era of we cannot share data except in certain circumstances to an era of we must share data except in certain circumstances. Has it seemed that way to providers?
So it is an interesting paradigm shift. If you think about the patient's data, it has always been their data, but we have made them jump through a number of different processes and hoops, so to speak, in order to gain access. The Cures Act is actually changing that to where they have the right to access the data that's theirs. It is a paradigm shift for some of our providers, and it really kind of depends. We're not seeing it universally across all providers, but we are seeing maybe some individual physicians who have a challenge or nurses who have a challenge, but it's just the journey of change. And I think that's why it's good that this is being implemented in a couple of phases. It allows for opportunities to get comfortable before it's everything being shared.
Understood. Well, and I think it's been interesting how the concept of medical record, that phrase has evolved over time, because when medical records were first put together, it was provider-focused documentation of who is this patient and what is the care that I provided in order to provide continuing care. And then, as we know, to move between providers as well. So I understand maybe some of the mindset challenges that particular clinicians might have with this is how I keep track of what I'm doing and how I know what's happened to the patient before versus this is something that the patient owns. Although to your point, it's always been the patient's data, right?
Yeah, absolutely. And I think that is part of it. What it's forcing is some people to rethink how they document. And I think that is more of the shift. If you think about some of our physicians who are graduating now from medical school and residencies, this is more ingrained into what they do, and they have a much more of a patient consumer focus. Whereas some of our more mature physicians, it wasn't part of their education or training. And so this is a different kind of rub. That's kind of where that challenge is occurring. What they're documenting can not just be read by another clinician, but it can be read by the patient. It doesn't mean that they shouldn't use the medical terms and everything that they use, but you may want to exercise a little caution in kind of what you're actually putting in the document, which has always been actually part of their medical record.
Certainly. Although not something that patients have maybe felt, to your earlier point, that they could easily access or that they needed to access. I mean, we're certainly in an era where patients seem to really embrace, this is my medical information, I want to have it and I want to understand it. The idea that that influences the way that providers go about documenting their care makes a lot of sense.
Historically, as the EMR has evolved, there was let's define what's a medical record. We kind of put up classifications, said these are things that are part of the medical record, and this is what we'll release if someone asks for the information. That is changing with cures, which is all of it in the not too distant future will be part of a full release. Depending upon where you live, different states have different requirements as well around that. Ohio, we retain the metadata.
Which is a perfect segue to what my next question is to talk about some of the technical challenges that you've encountered as we've worked to really meet the spirit of cures and of patient access. I'm curious, have those technical challenges been in particular areas? Has it been keeping up with what the EMR allows you to do or enables your health system to do? Has it been different EMRs talking to each other? Where have you seen sort of the bulk of the technical challenges to meet these requirements?
That's a bit of a broad question, so I'll do the best I can to kind of put it in some chunks. I'll just start with the EMR component of it. OhioHealth uses Epic as our EMR. If you stay current with that, they are following the same rules and regulations as everyone. So they're making changes as rules are issued, clarifications of rules are issued so that they can keep you current. Part of that then becomes the health system's responsibility to stay current with those versions and those upgrades. And so we have a pretty concerted effort and we do quarterly releases that give us the major content. But if a rule changes in the middle and we need to take additional updates, we'll do that. And so part of that is dependent upon each health system's view of how frequently they take those upgrades and how current they stay on their software and their version. Another wild card that kind of comes with this is the ability to provide this data to patients in the app that they want to have you send it to. That's where you're working on APIs, which is the ability to hook into the system and send the data. It has a little bit more grayness with it. And I think every health system's in a different spot in their ability to fully leverage APIs. Our vendor has released the FHIR-based APIs that are necessary for the exchange. And we have spent time working on the standard of this is the standard API definition, so that we can publish that. So if someone asks us, can you send to this app? Can you send to MyFitnessPal, for example? We would be providing them the specs. And if you can meet these specs, then yes, we can send it. If we can't, then we can also provide them alternatives to send. But we have spent a fair amount of time working through those processes. And so a lot of this is actually kind of in that last bucket of you've got to have the right processes to outline all of those pieces, because it's taking what has historically been viewed as a health information management and HIM responsibility and moving it more to where the patient owns, saying, hey, I want you to release this. It changes the processes we use. So we still need the standard release of information processes if it's being requested by a certain specific body that's not the patient or the patient's approved proxy. But if it's the patient, we should be able to release it to it. And that is just a different nuance that we have had to work through with people who've also been doing their job the same way for a long time.
which all of that makes me think of not only the extreme manpower behind making changes like this, but just the costs involved. And have you found that the costs have been a barrier or a challenge in any way to getting where you need to go?
For us, no. And it's probably because we're being very purposeful about thinking about moving towards a more digital consumer-faced healthcare system. We need to be investing in the technology that allows us to integrate differently, the technology that allows us to leverage the APIs. And so we were already on that journey. So this for us did not create extra spending. Now, if you're a health system that hadn't done that work, then perhaps it would increase spending and or needing to get some either full-time roles or consultants to help work through that transition. Because if you don't have the skill set, that would be the other thing that's the challenge.
Let's talk about how all of this has changed the patient's experience. That could be a very broad question, but obviously there's been a lot of focus on the patient portal as a mechanism to provide information to patients, as a user-friendly way for people to get their information. I'm curious what your experience has been like focused on the patient portal part of all of this and what the challenges have been with the portal.
Great question, because I think, again, this is going to be a little bit specific by health system, but if you think about that patient experience, to really make a rich patient experience, to get them engaged in their care, to help them be part of their healthcare journey, we want them leveraging the portal. So we want them to be able to log in, we want them to be able to understand the data, we want to be able to push things through there, we want them to be able to use their portal to schedule appointments, to find services, to do those things. For us, using that portal as a mechanism to exchange this information is a natural first landing point. If we can use that portal, then maybe we can also connect with people who haven't robustly used their portal. And this gives them the opportunity to actually see what is in the patient portal and the things that may be beneficial to helping them take better care of their own health. We're looking at a kind of how do we leverage it for those who already use it, but how do we connect with people who maybe only sporadically use it or signed up once and never logged in again, or just never logged in? And so this gives us a different mechanism to do outreach.
Have you seen significant increase in the number of patients using the portal year after year?
Oh, yeah. We probably are sitting in a high-end range of use of our portal. We probably have about 60-ish% of our patients are using the portal. So if you think about patients who have gone to the portal 3 or more times in the last 12 months, that's like 75%. So part of this is you've got to see people to get that value, but the value comes from us continuing to look at what we can make available in the portal. Can you schedule your appointments with your primary care? Can you schedule with a specialist? Can you schedule for urgent care? People think about urgent care as being the drop-in. For us, urgent care, we're looking at it from 2 ways. Yeah, you can drop in or you can schedule it. And then you're not just waiting in the lobby, but you may not have to show up until right before your appointment. And so we're trying to change that experience and we're leveraging the portal to do that. And so for us, this data about the patient going to their portal allows us then to think about how to use the information differently to reach them, but also to spend time with them. We have user experience strategists that work with us that talk to our patients and say, what do you like? What do you not like? What do you wish you could see? What do you wish you could see differently? Because a lot of times it's not that the information's not there, but we have not made it intuitive to the person searching for it. And that's part of the feedback we've actually heard with Cures is, whoa, this is a lot of stuff. And part of it is a little bit of they've never had it. We understand that. But part of it is we're thinking like healthcare providers. If you're a patient, you're not thinking that way. And so you're thinking about it, how is it logical for them? So we're really spending time with our user experience team, our customer experience teams to say, okay, what feedback are you getting? And how could we think about this push of information differently?
Yes, it's interesting to think about how the patient's thinking has had to evolve as they've gotten more comfortable with portals and all the things they can do to manage their healthcare and health services through the portal. One area that I've seen a lot of chatter on and had some fun discussions on is the classic patient that says, give me all my records. I want all of them. And of course, we have the ability to do that and we can push them all. But to your earlier comment about the patient gets in there and is overwhelmed by what is all of this, actually, that's not what I wanted. I just wanted this subset that I didn't know how to really describe or to ask for. Have you thought about that type of patient? They say, I want everything, but when you're pushing everything, you have to present it in a way where they can actually find what they're looking for. I mean, that's really difficult.
It is difficult. And that's why we've been very purposeful about engaging our user experience team, because they're helping teach us what's the best way to ask the next question to them. Great, we can do whatever you want. Give us a baseline of what you're looking for so we can help group it in something that makes logical sense to you. Or is this about a specific condition? So part of it is we try and get a little bit more information. Sometimes that's successful. And sometimes it's like, well, I don't know what I want until I see it. And so what we've also said is, okay, we're going to give you everything. If you have questions, please reach back out because we may be able to help you find it. We're also using those feedback opportunities as a way to say, gosh, we could consider logically sorting the information differently. Now, some of it we may be constrained by our EMR's portal, but a lot of it is us and how we think about it. And so we're trying to gain as much feedback and empathy from our patients and our patients' proxies as we can.
Just out of curiosity, have you ever had a patient share that they were surprised to find some of their information in there? And the way that I'm coming at this question is thinking about if I have visited one of OhioHealth's hospitals. Let's say I've been at Riverside Methodist Hospital, and so I want my records from OhioHealth, but I make a broad statement. I want everything. And so when I get in there, I see actually records from a physician office visit from, several years ago that I didn't expect to see in there, and kind of question, why is that in there? Do patients understand, not only all my records is a lot of records, but it's coming from different types of providers than they may expect. It's not just coming from the hospital that they maybe visited in the last couple of months.
Yeah, we've actually probably had it more the other direction where they're like, I didn't know I was going to get all this hospital stuff. The way I would think about this is I think that if we remember the fact we're still a little bit on the journey. So right now, even our version of all isn't the full version of Cures All that will come in the future. We know what's coming and we're planning for it. And if we can release ahead, we will. We do have people who, there's a lot there. They're trying to get their arms around it. We've also made a decision of, we kind of made a cutoff. We're like, we're going to start sending data from this point forward. We can go back and retroactively send other data from the past if they ask for it. If you're talking about specialty patients who may have multiple visits a year and multiple hospital trips, I mean, it could be overwhelming. So we kind of just put a mark in the ground and said, okay, we're going to go forward from here. As the rules change, we'll continue to expand, but we did determine we have the capability to go back and add if they request it. And that's a little bit how we're trying to manage that. And part of what's there also depends upon how long has the patient been with us. Sometimes we have people who may have seen us a lot in the last year, but prior to that, they moved in from another state. The interesting piece is through some of our interoperability, we have the ability to pull in some records from other care sites. And if we have pulled it in for our use, we are making it available to the patient if they request it.
Can you talk about some of the challenges that providers face as they're thinking about pushing data to the portal? One example that I can think of is when you have data related to services that a minor, a person who's not an adult, may be able, either under state law or otherwise, they may be able to request certain services. The records associated with those services may not be accessible to their parent or proxy, but parsing that data within one portal that a parent, for example, may have access to, likely a technical challenge, but I would love to hear your experience with that.
There are definitely opportunities in that space. We've spent a fair amount of time really working with our internal, external counsel on what can not be shared. We kind of started with what you can't share, because that was actually an easier, because if we started with that, then we were going to make the assumption that blocking anything else would be information blocking until we could work our way through if that was a true or false statement. So we kind of defaulted to, we're going to send it all except for the things we know already, but via federal or state law, you can't share. That was an easier starting point, but even that had nuances to it. To your point, how do the proxies fit into this conversation? So it's taken conversations to make sure we're all on the same page and understand exactly what we're asking each other. As I'm talking to counsel of, this is what we're trying to do, and making sure that I'm being clear enough, not stating it in a way that gets an answer that I think, as opposed to the answer that I want, which is, can I do this or not? The technical pieces are mostly related to proxy access. The things specific for a patient, it's pretty easy to say, we define these don't go. Some of the behavioral health doesn't go. It kind of depends on what you're doing. But the proxy part has been the most complicated. We have worked with our EHR vendor to really see what we can do. And so it's a bit of a journey as the rule evolves and as we see people maybe asking for it in that space and we understand how it works. We're actually working closely with Epic, our vendor, to say, hey, this is what we're seeing. Is there a different way to think about this? So that they can also use that feedback to make any changes in regular updates that we receive.
What do you think the future holds in the broad category of data sharing? What do you see down the road?
I actually believe that we'll see more and more push to share data. If you really want to impact healthcare, if you really want to impact the health of our communities, the health of our individual patients, if you want to lower the cost of care, the more data you can share, the better off you are, because you're avoiding duplication, you're avoiding unnecessary tests and making sure you get necessary tests, maybe for health maintenance and regular screening. I think some of the bigger challenges that I see changes coming in are probably related to exchanging data with payers. That's a gray space right now. There are some rules, there are some you can, some you can't exchange. And then there's this big group in the middle of let's talk through it. I see that starting to gain clarity around that sharing because I think both the payer and the provider have anxiety over how the data will be used. And so part of this is everybody's starting to understand the purpose of this exchange is to do this for whether it's the customers of the payer or whether it's our patients or families for the provider. So I think that's where I see that. I see patients as they become more comfortable asking more and more challenging questions and maybe going back and looking at their data. I think it will actually change the environment we live in terms of some of the processes and guidelines and rules that we've established because they were all based upon a lot of things you can't do. And now it's almost the reverse of there's a lot of things you can do. We have to be super careful to not inadvertently block something because it's a leftover. That's probably the best way of saying it.
It's interesting to think about providers 20, 30 years ago that were more insular and now today have connections with so many different types of entities that touch healthcare. And so I'm curious what your experience has been like interacting with payers, interacting with HIEs, interacting with, any other sort of entity that is impacted by data sharing. Has there been a sense of, and this is, just a broad question, but has there been a sense of collaboration? Let's try to figure this all out because everybody's trying to muscle their way through it, understanding that so much of it is new and changing all the time? Or what's the vibe been amongst all those different types of partners?
It's been an interesting environment to very generically say, by and large, they're trying to figure out how to make it work. I just think there's a lot of things that we need to continue to think about, making sure that as CMS, ONC, everybody starts to change guidelines, change requirements. How does that impact this data sharing? It's really making sure that we're listening to each other of what each group needs. Ultimately, you're thinking about the patient at the center of that conversation. Is that patient or the consumer at the center of the conversation, then work your way out. That's an easier way to be thinking about the why you should share data. And you got to really then get super narrow on why you don't want to share that data. And it's largely around the patients, like, I don't want you sharing the data about these specific things. I see that evolving. I just think it's going to be a journey as we work with HIEs, even though there's guidelines for the exchange of data. So the ONC and the Sequoia Project did a lot of great work to start the interoperability journey with Care Quality and Commonwealth now being all together, eHealth, all following the same rules outlined under that. eHealth really started with ADURSA. It's there and the guidelines are there, but it's a journey to get every EHR to the same place, to look at it the same way, to think about it the same way. Exchanging a CCD or a continuum of care document, that's pretty straightforward. Going beyond that takes more work. I know, for example, that we can share more data between our system and another Epic system because we all are speaking largely exactly the same language. But even that, no two Epic instances are exactly the same. It is how do we get to those markers and those standards that allow for a much easier data exchange. It's evolving. There's a lot of discussions and finger pointing, and they're not trying to play nice in the sandbox. And I think it's a journey. It's a journey where everyone's going to have to figure out how do we best do this to take care of people. Because that's really what we should be trying to do. And how do we put that information in the hands of our patients, view them as consumers so they can make their own decisions? The pandemic, if it's done nothing else for healthcare, it has changed the landscapes where people are realizing, oh my gosh, there's so much you can actually do while I'm still sitting in my house. And that's because we can start to exchange and think about data and connecting with them differently. I just see that continuing to expand.
I really like how you bring everything back to the patient. I mean, I think that is not only just in keeping with what these laws are about, patient access and ability to have information about themselves and make decisions based on that, but it's such an important North Star for everyone to follow. As you reference, in those times where there may be some conflict or tension between different types of entities holding patient data, to keep the patient as the North Star is such a good way to view it.
It's a little bit of thinking about that patient at the center and phrasing the question as, how can we do this, as opposed to identifying the reasons we can't? And historically, we've been much more around the reasons something won't work or the reasons you can't do something, as opposed to, okay, what needs to happen for this to be true? And I think that is changing that mindset and thinking that way. That is what, if anything, that healthcare systems can learn from the digital disruptors in our environment, is because they are 100% focused on that as a consumer. And they're looking at that consumer and that consumer data and how do I reach them where they are? We've historically thought about they need to come to us and we know what's best for them. Well, we've now taught them in the last couple of years, that's not necessarily true. We can come to you. And so we need to continue that piece. The litany of opportunities for digital disruption are extreme. Shoot, Dollar General believes that they will be the healthcare provider for rural communities, because you go to a rural community and you can find a Dollar General. That changes how we need to think about it.
Wow. It's fascinating to think about that. Potentially, we should all mark our calendars to have this exact discussion in 5 years and see if that has come true, because it's moving so quickly.
I think 5 years is too long.
Oh, my goodness.
I think each year you're going to see significant shifts. And I think in a couple of years, for those who don't invest in the journey, will be left behind.
And they'll be so far behind that it's impossible to catch up at that point. Nivedita, what do you think about all this?
You both have had a really great discussion here, and I think it's been an important one. And especially on your last thought, Andrea, about what this timeline looks like 1 year, 2 years, 5 years from now. I think as a final thought, I just wanted to see long-term, short-term, in the next year, what do you think are going to be the biggest benefits that patients and providers will see as a result of this enhanced kind of outlook on interoperability in the year 2022?
If we think about this correctly from a healthcare provider standpoint, what we've done is provide information to our patients to get more involved in their healthcare and be better involved in their decisions, teaching them what the data means, teaching them how to get to it, helping them understand the importance of health maintenance and why getting a colon screening at 45 now is the thing you should do. But maybe you don't have to go get a scope. Maybe you can do a Cologuard. It's teaching them those things and pushing that data to them and then teaching them how to use it. If we can do that in this calendar year, that's a success. And I can see that because the consumers are now understanding that they want healthcare to look like Amazon, where it's easy, it's on their phone, they click, stuff happens, and it shows up like magic at their door. That's how they want healthcare to be. And if we don't invest and use this opportunity with this exchange of data to help get there, we'll be left behind.
Great. That's a great final thought. Andrea and Jenny, thank you again so much for joining the show today. It was a pleasure having both of you here.
It was great to be here. Thank you so much.
Thanks. Really appreciate the opportunity.
I also want to thank the audience for listening to our special podcast series on interoperability. Coming up next in this series, we'll be hearing from the HIE perspective. If you like what you hear today, please subscribe to the show. Diagnosing Health Care is available wherever you get your podcasts.
Thank you for listening to Diagnosing Health Care. For show notes on today's episode, additional episodes, and more insights on trending issues in healthcare, please visit diagnosinghealthcare.com and be sure to subscribe on your preferred platform. The Employment Law This Week and Diagnosing Healthcare podcasts are presented by Epstein Becker Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of the legal services to be performed is greater than the quality of legal services performed by other lawyers.